Hello? Who can hear me? You can just unmute your mic and speak if you can hear me.
Yeah,
we can hear you now. We're not hearing you.
I can hear you
now.
Good evening, Chief.
It's network then. I've been talking since. Anyway, so I'm going to the next question. You cannot hear me, but you are replying my...
We can hear you now. We can hear you now. I mean previously.
Okay. All right, so the next one. So which arrhythmia is associated with irregular pattern on ECG? We have atrial flutter, atrial fibrillation, ventricular tachycardia, and supraventricular tachycardia. These are the options. I'll put it in the chat box. Okay. We have a lot of people choosing atrial fibrillation. But if this question says irregular, okay, the answer would have been atrial fibrillation. But under this circumstance, option A will be the answer. There's a difference between irregular, and regularly irregular. Cardiology students. So the next question. So atrial fibrillation will cause irregular breathing. So still on ECG, I want us to use today and touch ECGs so that when you see it later, it will not look strange. Which of the following ECG findings is indicative of right ventricular hypertrophy? Deep S waves in V1 and V2, tall R waves in V5 and V6, ST elevation in lead 3, T wave inversion in lead 1. Okay, let me put the question here in the chat box. So the way to look at it is that there's something called the Sokolo-Leon. Okay, let me take you to Sokolo-Leon formula. So Sokolo-Leon formula is actually used for left ventricular hypertrophy. But you will get why I'm mentioning it, even though this question is about right ventricular hypertrophy, in a minute. So the formula is that for you to know that a patient has left ventricular hypertrophy, you use R wave inlet in V1, okay, or 2, okay, R wave inlet V1 plus S wave inlet V5 or 6 is equal to is less than, okay, let me say, is less than or equal to 35 millimeters. So if you measure the R wave inlet V1 and add it to the S wave inlet V5 or V6, okay, if it's more than 35 millimeters, that means there's left ventricular hypertrophy. Okay.
This is right ventricular hypertrophy.
I said listen that I'm going to show you why I'm referring to this one first.
Okay. All right.
So right ventricular hypertrophy, for left ventricular hypertrophy, if you sum these two up, it should be more than or equal to 35 millimeters, right? So that tells you that that's the Sokolo-Leon formula. So for right ventricular hypertrophy, you consider the S wave inlet V1 or 2. Okay, so if it's more than it's I think 10 millimeters, okay, or you do S over, there's a ratio anyway that you have to do. So the point is that the right ventricular hypertrophy is like a reverse of the left ventricular hypertrophy. In left ventricular, you are considering RV1, okay, but in right ventricular hypertrophy, you are considering SV1. So that's basically the point of that question. So option A is the answer.
Okay.
So which ECD finding is characteristic of atrial fibrillation? Option A is P waves with variable morphology. Option B is regularly spaced QRS complexes. Option C is absent P waves. Option D is wide QRS complex.
Absence.
So which of them is like characteristic of atrial fibrillation? Of course, the characteristics of atrial fibrillation include um, absent P wave. Okay, a normal ECG, you expect P wave followed by a short distance, followed by Q, R, S complex, followed by a T wave. Okay, then followed by another P wave. Just repeated pattern of this. So this is the P wave. P wave. This is the Q. This negative deflection is Q. That's on, let's say we are considering lead 2. So P, Q, R, S, T. Okay, those are the waves, the basic waves. So on atrial fibrillation, this P wave is going to be absent. All right, so there's absent P waves, and then there is usually irregular pattern. Okay, so you expect that the space between one QRS and another QRS is going to be dissociated. All right, so you cannot really say this is the number of waves. All right, then what else? They have like what do you call it, tachycardia. Okay, so the number of ventricular rate is going to be very high. All right, so those are the features of atrial fibrillation, or the common features. So irregular, absent P waves, and tachycardia. So this question says sawtooth pattern in lead 2 on an ECG is indicative of which arrhythmia? AFib, A-flutter, VFib, SVT. So basically, instead of having one P wave, like the normal one I drew above, it's going to be having waves that look like this. So something like that anyway. So sawtooth appearance is classic for atrial flutter. So there's something very important to discuss about. In fact, there are a lot of things to discuss about ECGs, but like if you talk about the waves, then you also have to talk about the, their intervals and segments, because they all relate. So this question is testing your knowledge of segments. Which ECG finding is characteristic of a myocardial infarction? ST segment depression, T wave inversion, ST segment elevation, prolonged QT interval. So coming back to our normal okay. From the beginning of this one, oh, to the beginning of the QRS too. So that's going to be called a PR interval. Okay. So a segment is like from ST is QRS, right? So from the end of this one to the beginning of this one. So that's the ST segment. Okay. And this ST segment is very, very important for myocardial infarction because it changes very quickly when a patient has a myocardial infarction. So you can see how this one is. There's something called the isoelectric line. So this line, that straight line, okay, if you imagine that this is a straight line cutting across all these waves and segments, okay, that's called the isoelectric line. Okay, so that line, if you get this wave being significantly, let me use another color. If you get this segment, okay, being significantly above, that tells you that there is elevation of the ST segment, and you tend to see that in myocardial infarction. Okay, so that's that about it. But you can also have ST depression in late stages of myocardial infarction. So that early time, what you have is ST elevation, but much later, you are going to have ST depression. All right. This is another thing that they're going to test you on ECGs. The knowledge of the, you know, biochemical diseases that can cause ECG changes. So the presence of a U wave on an ECG is most commonly associated with which of the following conditions? There's hyperkalemia, hypokalemia, hypocalcemia, hypercalcemia. Of course, it's hypokalemia. So, what are the ECG findings of hyperkalemia? Who can tell me the ECG findings of hyperkalemia? There are three major ECG features.
There's tau tinted T waves.
Yes.
Okay.
There's prolonged PR interval.
Okay.
Not sure. Huh? That's it. So I know, Chief.
Widened QRS complex.
Peak T
Okay.
wave as well. Peak T wave as
Widened
well.
QRS and absent P waves, I think.
There's a peak T wave.
Okay, so yeah. So tau tinted T waves, widened QRS complex,
Yes.
and PR interval prolongation.
Yes.
Okay, so those are the three major findings of hyperkalemia. And you cannot miss it because it may come out in your exams. So ECG evidence suggesting pulmonary embolism includes the following: T-wave inversion, S1Q3 T3 pattern, T-segment elevation, prolonged QRS, prolonged RR. These are the kind of questions that once you know it, you'll be happy because it doesn't change. Pulmonary embolism causes,
Is B.
one of the evidences suggesting pulmonary embolism
Is B.
on ECG is S1Q3 T3 pattern. But that S1Q3 T3 pattern is not always present. The commonest ECG finding in pulmonary embolism is a tachycardia.
ET.
Okay, but the finding that is most marked or most characteristic of pulmonary embolism on ECG is this S1Q3 T3 pattern. All right. So another disease that is also tested on ECG is pericarditis. Okay. So pericarditis can also cause ST elevation. All right, but there's a type of elevation it causes that is called saddle elevation. So you know how the horse is now, the saddle of a horse. So it's going to have a small notch in the elevation. So that's why it's called the saddle elevation. A saddle elevation. So this is the saddle, just a small notch on the top. Okay, so that's pericarditis. Saddle elevation. So another thing about the ST elevation of pericarditis is that it is generalized. Okay, unlike the ST elevation of myocardial infarction, which is contiguous. The meaning of contiguous is that, remember that we talked about the blood vessel to the heart. Okay, so each part of the heart has a different blood vessel. So at each point in time, when a patient is having an MI, or a patient is having like a an event, a cardiovascular event, okay, a heart attack or something, it means that one of the blood vessels is obstructed. So it is that particular place where that blood vessel is supposed to supply that is going to have the issue that will show up on the ECG. Okay, so it's contiguous. You'll be able to see, based on the findings on ECG, you'll be able to tell, is it an anterior MI, is it a posterior MI, is it an inferior MI? And from there, you'll be able to, postulate or reverse engineer it, okay, to say, okay, this is where I think, this is the blood vessel I think that was affected, this is the part of the heart that I think was affected, just based on that ECG finding. But for pericarditis, everything is affected, both lead V1, V2, V3, everything, AVF, lead 1, lead 2, lead 3, everything is affected. Okay, so that tells you that it's generalized. So it's pericarditis. All right. Somebody doing taxi. Okay. On cerebral malaria, caused by hypoperfusion, caused by sequestration, caused by P. malaria. It's a medical emergency and should be treated with parenteral drugs. So which of them is the answer? Remember that your exam, if you see options, many of them could be correct, but usually, um, okay, well, it could be an except question, but you can also think of it that it's the best option. Okay, so if it's an except question, you will know what to choose. But if you are really looking at the best option, only one like is the best of the options. So your exam is also a best option exam. So always remember that. So option D is the best option if you are looking at it that way. Cerebral malaria. But if you see an except in the exam, what will you choose?
I'll go for A. No,
E.
yeah.
I think it should be C because of Parum.
If you see an except in the exam, it's obviously caused by B falciparum. So B falciparum is the most virulent form of the parasite, right? So of the protozoan malaria. So it's expected that P. falciparum is the one that will lead to cerebral malaria. So P. malaria is less likely, it's least likely to cause um, cerebral malaria. So how will you manage a patient like this? If you were asked to manage this type of patient, what will you do?
We give parenteral test units.
Parenteral artesunate at what dose? Many of you are into
At three,
private practice or one place or
at
the other,
three,
so you should have to.
at 3 milligram per kg. If a patient's weight is more than, if it's less than 20 kg, but if it's above 20 kg, we can use 2.4 mils per kg, milligram per kg. Then afterwards, after the test unit, the patient can be converted to oral ECT.
You say 3 milligram per kg.
Yes, above
How frequently are you going to give the
12
patient?
12-hour interval of 12
Yeah,
hours,
0, 12, and 24.
and 24 hours.
Okay,
Yes.
that's the regimen. But it's 2.4 milligram per kg.
When
Okay.
it's above 20, if the patient's weight
These
is
are
above 20
we are
kg.
in adult medicine now. Which
Okay,
adults will
yes,
be
yes,
weighing less than
yes,
20?
yes, yes, it's true. It's true. You're correct, sir.
So you will now manage the patient that way. Of course, you give your IV fluids because
Yes, yes,
if it's cerebral malaria, you expect that. In fact, when you admit a patient, you're supposed to maintain the patient on fluids. Okay,
yes,
so you also give something that will contain some glucose, like
yes.
dextrose,
This was
5%
water. Yes.
dextrose, saline, or something, because of the risk of hypoglycemia with things like
Hypoglycemia.
this.
Yes, yes,
Yeah, so you need to do a holistic approach. Also, IV paracetamol will also be in order because if it's cerebral malaria, the patient may be confused, may not be able to take orally. Okay, so IV paracetamol, you expect that there should be some fever now as well.
Mm,
So
mm.
you manage holistically. Okay, and then gradually, when patient can now take orally, you convert to
Also ECT.
ACTs,
Yes.
oral ACT, and do the normal regimen. So
Mm.
all right. The next question is about Bromocriptine is used in all the following except galactorrhea, acromegaly, gynecomastia, Parkinsonism. In which situation are you not going to use bromocriptine?
D.
What's bromocriptine? Bromocriptine is actually a drug that stimulates the dopaminergic receptors. It's a dopamine agonist. So what happens in Parkinson's disease? Parkinson's disease is as a result of depletion of dopamine
Dopamine.
in the substantia nigra of the brain. So um, bromocriptine can be used to treat Parkinsonism. It's part of the treatment. On the other hand, the drug that causes Parkinsonism is antipsychotics, okay, like haloperidol, chlorpromazine, all those type of drugs are the ones that causes Parkinsonism, right? So those are the ones that you should avoid. Then can be used to treat some forms of acromegaly because of the pituitary gland inhibition. Then dopamine is actually prolactin inhibiting hormone. If you think of it this way, another name for dopamine is prolactin inhibiting hormone. And we know that prolactin is involved in what? Galactorrhea.
Galactorrhea.
So the only odd man answer is option C.
Gynecomastia.
So positive inotropes, like medications that cause contraction, they're called inotropes. While chronotropes are medications that cause that increase the heart rate. So positive inotropic agents, diisopyramide, adrenaline, verapamil, potassium, and metoprolol.
Adrenaline. Adrenaline.
Metoprolol. So each of them is okay. I've not posted it
Is adrenaline.
because this is giveaway question now. This is Salaka question. So this question says fruity odor in urine is found in option A, UTI, DKA, alkaptonuria, and chyluria. Which of them do you find fruity odor in urine? This one is also another giveaway question. Because it's DKA.
Mhm.
That fruity smell. The smell of ketones. So which is not a criteria for diagnosis of nephrotic syndrome? We have hypertension, massive proteinuria, hyperlipidemia, and anasaka.
Mm.
Hypertension, massive proteinuria. Okay, so of course it's hypertension. We already discussed nephrotic and nephritic syndrome the other day. Okay, you guys should be attempting this question while I take my call. Classic sign. Okay, so which is not a symptom of raised intracranial pressure, alters consciousness, headache, non-projectile vomiting, convulsions. Um, we expect projectile vomiting actually in raised intracranial pressure. So the following is a sex-linked disease. Option A, yellow nail syndrome, cystic fibrosis, Lex-Nyhan syndrome, PKD. I think if you try to do elimination, there's something about genetics that is very relevant. The common genetic diseases